this is bad.
Going viral.
All right. When you're doing your 12 leads, don't get in my face, all right? This much.
Get out of the way. Don't face the camera.
Camera that way. So if you're looking down at the heart, you're looking at the right ventricle, left ventricle. Again, the walls are different. Left anterior descending artery, left circumflex artery, right coronary artery. Okay? So if we occlude the left anterior descending, we're on the anterior side of the heart. When we occlude the left circumflex, we're on the lateral side of the heart. And when we occlude the right coronary artery, we're on the inferior side of the heart. So if I occlude the left anterior descending, I'm going to kill part of the septum, and I'm going to kill part of the anterior side of the heart. So this is, LAD may be an anterior septal or an anterior lateral infarct. Okay. If I kill the left circumflex, or I block it, I'm going to start to kill the lateral side of the heart and part of the inferior side of the heart. So I end up with a inferior lateral or an anterior lateral infarct. Okay. And then if I kill the right coronary artery, I end up killing the inferior side of the heart, part of the right side, potentially, and the septum. So I see an inferior septal or an inferior MI, and this is where I have to go and do my V4R. Come around and see how much of the inferior side of the heart's being killed. So when you look at a 12 lead, what am I looking for on the anterior? Anterior septal. So I'm looking at V1 and V2, and what am I looking at here? V3 and V4. So V1, V2, V3, V4 elevation tells me it's the left anterior descending artery that's blocked. Okay? When I come over here to the lateral side, what am I looking at? V5 and 6. What else? 1 and 2. What's the other one? ABL. Okay. Okay. And now when I look at the inferior side, the right coronary artery, I'm looking at 2, 3, and AVF. So if I see elevation in 2, 3 AVF, I think right coronary artery. If I see elevation in V5, V6, lead 1, and lead 2, or excuse me, AVL, I think left circumflex artery. And if I see V1, V2, V3, V4, I start thinking anterior septal. So septal is V1 and V2, anterior is V3, V4. Because this is what we're looking at as far as the artery is concerned. When I start to look for ischemia, right, ST depression type deal, that's when the endocardium has started to die. Because if I block the coronary artery, we feed from the outside in, because that's where the coronary arteries are, so the epicardium is going to get blood flow, the myocardium is going to get blood flow, and the first place I'm going to cut off blood flow is the endocardium. So as the endocardium starts to die, I start to get ischemia, so I get ST depression. As the endocardium continues to die and it moves into the myocardium, that's when you're going to start to see ST elevation. So we go from death of the endocardium to death of the myocardium starting to occur. When death of the myocardium starts to occur, you get ST depression or ST elevation. So this is your STEMI. So by the time you see a STEMI occurring, you're already looking at endocardial death and you're looking at myocardial death beginning at that point. If I have death, a complete blockage of this coronary artery, and it dies all the way up, that would be literally this whole wall from inside out. This is what they call a transmural infarct. So the whole wall died from the outside all the way to the inside, or actually from the inside all the way to the outside. So what happens here is the tissue is all dead in that spot, so now it has to go back in and it has to rebuild, and that's where you end up with scar tissue. So this is going to be a big scar area. As a result, there's no electrical activity going through that spot, and there's absolutely no no contraction. Okay, so we have no muscle contraction here because this is all collagen and scarring. This is just endothelial tissue at that point. So as a result, what's going to happen as far as your EKG is concerned, you're going to have the heart's going to have to bypass that area. So the potential is I'm going to see a branch block because that portion of the heart has to go around. I may see an axis shift as a result, depending upon whether it's on the right side of the heart or the left. Now, looking at this diagram, what side of the heart does tend to be dies in a heart attack? Left side. So for the most part, left side of the heart's going to die as a result of the heart attack. Depending upon how bad this is, it could cause the right side to work harder, and then we end up with right-sided ventricular problems, and this is what we end up with as far as congestive heart failure is concerned. Because when the left side starts to fail, where's it back up into? The lungs, okay? And as the lungs start to build up pressure, we end up with pulmonary hypertension. And as the lungs develop pulmonary hypertension, the lungs start to back up into the right ventricle. Right ventricle has to work harder, so it starts to stretch and get bigger. It's called cor pulmonale. And as a result of cor pulmonale, we end up with back up into the body, and we start to see edema. So when we start to see something like that, so left ventricular failure, cardiogenic shock potentially, weakness, backing up into the lungs, we end up with pulmonary hypertension. Cor pulmonale, as a result of the right ventricle having to work harder against that pulmonary hypertension, backs up into the body, we end up with edema, and as a result you end up with a patient who's got pulmonary hypertension, a little bit of pulmonary edema, we have peripheral edema, congestive heart failure. Okay? That's it. Trying to explain coronary artery